Over to Dr. Rahul on Yadav.
Thank you, sir. Great to see you all after so long this one. Am I audible, sir? Am I audible?
Yes.
Yes, sir. I'll just share the screen, sir. Good morning, friends. It is great to be here in the morning with you all. So today's topic is actually intact preterm survival. So that topic actually, we can actually go to the more, what we can say, more challenging part is intact extreme preterm survival. So extreme preterm means what? The viability limit has been actually being shifted towards left side. In last century, viability limit was 28 weeks of pregnancy. It became 25 weeks. Then it became 22 weeks. So this 25, 28, 22 weeks, they are not just numbers. There is a doubt whether by treating this baby, we're actually converting mortality into morbidity. So how to improve these survivals? Why this neurological dysfunction happens? And is it possible actually to give these babies some good quality of life afterwards? These are the actually burning questions in everybody's mind. So when you are going to find out the answer, whether is it possible to get a good intact preterm survival in the extreme preterm babies, there are very few data from Indian sources. So let us see some data from our own experience. In our own experience, it is actually we are focusing on predominantly 26 weeks or less. There's 25 weeks, 24, up to 22 weeks also. Right from 750 grams up to 380 grams. So some babies about 308 grams or so. These are the babies almost in 3 years. So what we came across is we got almost this 32 babies which are 25 and less weeks gestation. On follow-up, we have got 30 babies. Out of that, we observed that neurologically intact survival is 23. Now, neurologically intact means what? That particular terminology means different thing for different people. Many times the baby is able to walk, talk, but he's having behavioral problem. He was having soft neurological signs. So how to assess them? So for that, what we did is ages and stages questionnaire. It's a questionnaire which can actually, those babies who are not coming for follow-up, we can call them and we can find out. Those babies who are coming for follow-up, actually we can directly do the examination. And what we found out is predominantly this questionnaire we use. What we found out is this. So these are total 30 babies, 25 weeks and less on follow-up, or 750 grams and less on follow-up. Some of them had prematurity as a predominant, some of them had IUGR. IUGR were faring worse than prematurity alone. If twins are there, one baby is having more IUGR, that baby had actually some amount of dysfunction afterwards. But those who are pure prematurity with smooth NSC course, they were having excellent outcome. So what we observed is occasional baby, one baby had a temper tantrum. One baby was having, two babies having squint, and only two babies we had motor delay. Now motor delay was in the form of their corrected age was 2 years, but they're able to walk with support, both of them. So we didn't come across any spastic quadriplegia. So this spastic quadriplegia is our nightmare, or spastic diaplegia is our nightmare. Inability to walk, inability to talk. Even one baby is too early for comment on development, because this baby is right now corrected post-concept age of 40 weeks. The baby already having head control and social spine. So we were surprised with this outcome that almost 23 babies out of 30 were having completely normal. Squint was there in 2, which is easily correctable. Speech delay was there. Speech delay means this one even at 18 months of corrected age, that baby was able to talk only monosyllables. Cognitive dysfunction was present when motor dysfunction was associated. Only cognitive dysfunction was not there. Motor delay was there in basically 2, and they are undergoing physiotherapy. So this 23 out of 30 is very reassuring, because we are dealing with the baby. Well, this particular study deals with the baby which is 25 weeks or less, which in past, just few years ago, we are considering non-viable. Even if they survive, we thought that definitely they are going to have neurological handicaps. So before going for this hows and why, first of all, we have to understand the reasons behind what are the causes of non-intact or problematic outcome in these extreme preterm. So once we go for that, previously we used to blame only gestational age. Then we started to blame weight. What we observed is a multifactorial thing. No one thing responsible for this. When we get a baby who is preterm and who is on follow-up, he is having CPMR or something, it is something happening wrong, going wrong at 4 places, not only one. Something gone wrong before birth, something gone wrong at birth, something gone wrong during NICU stay and at home. So it's a multifactorial thing. Now this multifactorial thing, when we correlate, what we observed is main problem what faces a pediatrician is the viability confusion. For example, suppose when you go for a call or when you get a LSCS call or normal delivery call, whether to restate the baby or not, that was the main confusion. Whether this baby we are going to give good quality of life afterwards. Now this viability is a relative concept. 28 has become 25, 25 has become 22. Now this viability confusion leads to sometimes irregular or delayed care, and that irregularity or delayed care itself creates fluctuations in blood supply to brain, and it can promote IVH. Second thing what we observed is reduced flow. Many babies are having PIH in mother. So mother is having PIH, there is abruptio of placenta and reduced flow to the baby before birth. That was one of the important cause of those babies who are having motor dysfunction. So what is the solution here? Solution here is active participation of pediatrician into decision making. Majority of physicians, they call the pediatricians when they decide about delivery. So instead of that, pediatricians should more and more take active interest in decision making around the birth, not only after the birth. So pediatrician can actually help the physician by zeroing out what are the factors, and we can make the decision more accurate. What we observed, another thing is bradycardia at birth. Now, perinatal animal, what happens is heart rate is going hand in hand with BP. Other than that, BP goes down, heart rate goes up. But in perinatal animal, heart rate and BP simultaneously goes down. So bradycardia is a surrogate marker of hypotension. So in this bradycardia, if you treat properly, because majority of these babies can't breathe on their own, they require intubation, they require bag and mask, they require some support. But along with that, bradycardia is something which is very, very important because hypotension produces peripartum ischemia of brain. So this peripartum HI, or traditionally we call birth asphyxia. So this peripartum HI is one of the important cause of this non-intact preterm survival. Now, how to treat bradycardia? Previously, in full-term babies or mild moderate preterm babies, once you bag the baby, then chest rise happens, saturation improves. So this chest rise happens, saturation improves, should not be the criteria for bagging these babies. Criteria should be improvement in heart rate. If improvement in heart rate is taken as something which is target, then automatically overzealous treatment of causing barotrauma to the baby comes down. Even if the baby's saturation is 80, 85, we can accept that. Avoid hyperoxia in labor and try to improve the heart rate. Good heart rate, good pulses automatically tell us about good BP, and that ensures adequate blood supply to brain. Next part is home, which is ignored many times. Malnutrition and aspiration. Many times what used to happen previously, we used to treat these babies successfully. These babies used to go home and they'll be brought dead. Sometimes these babies will be brought dead because of aspiration. Sometimes they'll be severely malnourished. And this malnutrition is called EUGR, extrauterine growth restriction. That is directly proportional to cerebral palsy mediated retardation in future. So once you go for this complete care, before birth, at birth, home care, that actually definitely goes a long way in improving the outcome. But that doesn't say that NICU is not important. NICU stays at the core of ensuring intact preterm survival. So NICU care means what exactly? So NICU care we can see as a whole picture. So this is a very important picture. Whenever we come across any brain-oriented registration or brain-oriented NICU care, then we have to always remember this figure. Now, what is this figure? This figure is the figure of a neuron. This is a basic unit of CNS. Now, on this figure, anything which increases, anything which decreases, both of them have got potential to cause problem in future. What are the things? There is increased pressure, increased intracranial pressure, hyperanatomic dehydration, hyperbilirubinemia, and seizures. Now, seizures, traditionally, phenobarbital was the drug of choice for long term. So, not all those things have to change over a period of time. That phenobarb has gone down, then levetiracetam has come. That we discussed soon. Another thing is flow. If this flow is reduced to the brain, so this reduction of flow happens in two epochs. One is before birth and after birth, along with bradycardia. And more importantly, at the second half of first day, hypotension, bradycardia, hyponatremia, hypoglycemia, hypovolemia, and hypocapnia. These are a full network of all the factors which can actually cause poor neurological outcome in newborns. So let's discuss it one by one. First of all, let us go with seizures. Now, seizures, once we see, we have to first of all understand that phenobarbital was a drug of choice for full-term babies, but is no longer a drug of choice for extreme preterm babies. So this is a study which actually compared between phenobarbital and levetiracetam. What they did is at the T0 means time at the time of convergence, and T1, that is after 1 month. They compared those who received phenobarb and those who received levetiracetam, and they found the tone and activity and feeding behavior was definitely better in case of levetiracetam, and p-value was significant. So phenobarb leads to depression of brain, leads to hypotonia, feeding issues, drowsiness. So, but levetiracetam does not affect the normal neuronal transmission. So it won't lead to that much of depressed brain. Of course, excess levetiracetam itself can induce sleepiness, but not sedation as like phenobarbital. So levetiracetam is the drug of choice for extreme preterm, especially those who are having myoclonic seizures, those who are having stimulus sensitive seizures. If you touch the baby, baby goes for myoclonus. If you talk, take round, baby goes for myoclonus. That is the time when levetiracetam is much better than phenobarbital. Now, is it safe really? Because it's a new drug. What they did in animal studies, because we can't do this study ethically in newborns, human newborns, but in animal studies, they have done the studies 5 mg per kg, 10 mg per kg, up to 100 mg per kg. 100 is pretty big number. So this 5 to 100, and they found no neurotoxic effect on that particular newborn animal neurons. Second thing, what they do, most interesting is the levet pill able to modify the disease? This is disease modifying phenomena of levetiracetam. Now, we have observed that these various therapies, including hypothermia, are in doubt right now. But levetiracetam is a drug which, when given, the apoptosis of neurons is less in those babies who got this particular drug. So not only it is safe, not only it is effective, but it can modify the disease. The death of the neurons, this drug can prevent. So levetiracetam has come up in a big way as far as newborn convergence occurs. Now, second part, we'll see bilirubin. Bilirubin, traditionally, so many graphs and charts are available, but these are not applicable for extreme preterm because they are actually prone for low bilirubin kernicterus. At very low level of bilirubin itself, they get kernicterus, and this is very difficult to actually treat afterwards. They develop tone abnormality, cerebral palsy, MR, and all. So, how to treat this bilirubin? That was another challenge what we faced throughout. So, this is let us make it more complicated rather than simplifying it. This is called as Hong Kong formula. This Hong Kong formula is a formula proposed by the conference in Hong Kong. This one. What is this formula? Risk of kernicterus is directly proportional to PTD. What is P? P is the rate of rise of bilirubin. T is total bilirubin. D is duration of bilirubin. Now let us forget about this. Let us go for further. EGCA. E is excretion. G is gestational age. S is solubility. A is albumin. M is metabolic status. N is neuronal status. B is blood-brain barrier. So forget about all complex. Now let us make it simple. Now among all those things, there are only 3 things which are in our hand. Only 3 things. Among these 10 things, we are having only 3 things in our hand. What is in our hand? One is E, excretion of bilirubin. Excretion of bilirubin happens by 2 ways. One is by urine, second is by stool. Now both these things we can improve by giving adequate hydration and early feeding. If you give adequate hydration and early feeding, that itself is sufficient. Not only we are reducing bilirubin, but we are saving the brain. So early feeding and hydration go much longer than any other therapy. Next is S, solubility. By phototherapy, what we are doing? By phototherapy, we are not reducing bilirubin. We are just changing the form of bilirubin from insoluble to soluble in water. So the solubility of bilirubin is improved by phototherapy. Now phototherapy, there are various guidelines are there. What happens practically is some Dr. A will find out jaundice, Dr. B will advise serum bilirubin, then bilirubin level will go, again it will come after a few hours, then decision of phototherapy taken back next round. It leads to loss of precious time. And that is the time when this vulnerable brain gets damaged. So there should be quick actually diagnosis as well as treatment starting about phototherapy. So this particular flexibility is very important. And last but not the least is M, that is metabolic status, that is metabolic acidosis. When acidosis is there, even at low bilirubin itself, total bilirubin itself, that bilirubin actually is unbound form and can go to the brain. So treat acidosis. Start phototherapy at right time. Give early feeding and ensure adequate hydration. That itself is sufficient for reducing the bilirubin-induced neurological dysfunction in these babies. Now, what to do actually? There's old theory. What to do is understand that low bilirubin kernicterus exists. So don't wait for the value. This value can be variable because there is a lot of variation in labs. Same lab, there is 10% coefficient of variation. Different lab, there are 20% difference. So don't change the lab. Even if you don't believe in bilirubin, you send to the same lab so that we can compare. Drawbacks of NICE guidelines. There are NICE guidelines are available, but at that time, less than 25 week babies were not there. Problem with these guidelines, they depend on bilirubin levels. Because bilirubin levels are majority times it is not correlating clinically. So we have to give freedom to NICU personnel to start phototherapy. Starting phototherapy should not require a senior person. Should not require always the senior most HOD should come and decide about phototherapy. Whether these babies, especially in first 1 week of life, they start looking yellow, that particular sister or doctor should be free to start phototherapy. There was a time when we used to do prophylactic phototherapy. Prophylactic phototherapy has not worked, but early phototherapy has worked. So Billy blanket and early starting of timely phototherapy is very important. Most important part is serum bilirubin slowly is going out of use. Now we are going importance to skin color. Skin color is picked up objectively by bilirubinometer. It's a bedside machine. Just put it on forehead of the baby or sternum of the baby, you will get value. And this value may not correlate with serum bilirubin. It doesn't make any difference. We can see the trend. So the whether phototherapy is working or not, whether required or not, these decisions can be done without any blood test. So this particular thing has been revolution in management of jaundice in extreme preterm baby, leading to improved neurological outcome. Now next is hyperanatomic dehydration. This hyperanatomic dehydration is very common in India because Indians we don't use incubators. We like warmers because incubators give infection. But this baby, extreme preterm babies, once they put on warmer, they lose weight and they develop definitely hyperanatomic dehydration. This leads to shrinking of brain shrivels, and it leads to convulsions, irritability, jitteriness, and it goes a long way for neurological dysfunction. So here for that, double-walled incubator is very important. Now, the double-walled incubator, what is the importance is, it leads to adequate humidity inside. Now we can see carefully, this baby being nursed, this baby is having some condensation is happening on the walls of incubator. Now this condensation should not be excessive, it should not be completely gone. So this humidification goes a long way in maintaining water balance. It goes a long way to prevent hypernatremic dehydration and thereby improving the neurological outcome. In this same picture, we can see the blood pressure monitoring. In the same picture, we can see saturation. This saturation should not be neither hypoxia nor hyperoxia. It should previously be from 88 to 91, but we are more liberal now, 90 to 95. Don't allow the saturation to go below 90. Don't allow it to go beyond 95. Also, go for the BP monitoring, blood pressure monitoring. In these extreme preterm babies, this particular traditional signs of shock like color and all, they are not reliable. So blood pressure monitoring and keeping the blood pressure between 5th and 50th centile for the gestation age. Last but not the least is pressure and number. Increased pressure and reduced number is a catastrophic event called as IVH, intraventricular hemorrhage. Now that intraventricular hemorrhage is the main enemy of brain. Now how it happens and what is the problem here? If you focus on this particular area is this is called periventricular area, germinal matrix. This is called as nursery of neurons or newborn neurons. Better term is newborn neurons. The neurons are formed there, and from there they migrate all over the brain and take the predestined place. Now, when there is damage to this by pressure or bleeding or ischemia, then this whole thing becomes problematic. Various names are there. Periventricular hemorrhage, some they call periventricular leukomalacia. So many terms are there. But ultimately, we are focusing on something around the ventricles which gets damaged in young preterm babies. What it leads to? It leads to increased pressure. It leads to decreased number. Now, this number decrease, there are two consequences. One is function is lost. Suppose that particular baby, that neuron was supposed to move the actual legs, and that neuron is gone. Then leg can't be moved properly. Tone abnormality comes. Or second is brain plasticity, means the neighboring neuron or the contralateral neuron starts taking over the function. So this reduced number and increased pressure is the main problem in these extreme preterm babies. So previously we used to observe this very helplessly, but we are no longer helpless. IVH previously just we used to observe IVH is there or not there. There's nothing like treatment of IVH. We tried a number of things like repeated LPs, flushing and all those things, but it failed. Now this one, it is new interventions have come up in neurosurgery. So neonatal neurosurgery has become a separate branch. What is this intervention? This is called Obeah reservoir. So we implant Obeah reservoir into the baby's brain. And now what is the advantage of Obeah reservoir? Is that this particular one end is actually lying in the ventricle. Second end, that the reservoir is accessible for aspiration. So see the anterofrontal and aspirate. See the anterofrontal aspirate. So by this method, we can keep the ICP at manageable level. Now there is no objectivity, it is subjectivity here. We have to palpate the anterofrontal daily and we have to aspirate the reservoir daily or alternately, depending on situation. By that, we can also see the color of the CSF. We can see turbidity of CSF. We can see the presence of infection. So this OMA reservoir has made a big difference in management of this IVH, where we can manage this IVH actually more objectively. Next thing comes up is what will happen with these babies. These IVH babies, there was a time when we used to stop ventilator. We used to withdraw support because of IVH, because we knew that IVH is associated with poor neurological outcome. Now, this is the biggest study we come across, Mehra. Why? Because it is a very huge study. Almost many hundred, almost 500 babies she has studied horizontally. And what she found out is quite interesting. It is quite recent study also. Grade and laterality of IVH to predict almost 18 to 22 months neurodevelopmental outcome in extreme low birth weight. So in this one, so in this ELBW infants with bilateral compared to those with unilateral, they had worse neurodevelopmental outcome, and infants with grade 1, 2, 3 almost had similar outcomes. So in this particular thing, she comes out with another nice statement as far as this is concerned. What to tell to parents when a baby is having IVH? What to tell to parents, especially extreme preterm baby when they are having grade 3 or grade 4 IVH? So that nice sentence is never lose a sight the mounting evidence that large number of infants with severe IVH survive into early childhood without impairment. So it is not as bleak as projected in the past. So this is the low flow state. Low flow state means this baby improves and then worsens because of hypertension. Because this happens because of hyperoxia and hyperventilation we can prevent. Last is sugar. Now sugar, there are a lot of targets were there. What has been actually proposed is very different target. 46 to 180 is a very long target, long range. So don't try for any specific 80 or 60 or something, right? From 46 to 180. If you target such a long range, it gives you a lot of flexibility because these babies, they tend to have more range of sugar than term babies. Now we'll come to the last. A lot of soft therapies have been proposed to improve the neurodevelopmental outcomes like kangaroo mother care, music therapy, light variation, touch therapy, oil massage, early stimulation, nesting, and noise reduction. But what happens is that these all therapies, they are quite good at mind level, but hard evidence is not in favor of any of these therapies because whatever studies are there, they are very small. And once you go for a sufficient sample size or multi-center study, they are unable to show any statistically significant difference or statistically significant change in IQ. Their objective is IQ in case of these preterm babies. The classical example is KMC. KMC was supposed to improve the brain. KMC was supposed to improve IQ. But long-term study of 20 years from Colombia, the original cohort, they failed to show any difference in IQ. In fact, there was IQ in KMC score, mean IQ was 87, whereas in control it was 88. So it doesn't mean that KMC reduces IQ, but KMC, we should not expect KMC alone is unlikely to improve IQ. So more important than that is something like a hardcore neurology like sugar, BP, and temperature and all. So even music therapy also they explored and they found no difference in case of those who received music therapy and others. So similarly, all the soft therapies are important. We are not against that, but we can't depend on that to improve brain. So take home message is seizures, levetiracetam is safe up to 100 mg per kg. This is modified. Bilirubin, ensure hydration, early feeding, use transcutaneous bilirubin, use of bili blanket, freedom to start phototherapy. IVH, early neurosurgery treatment. Prognosis is good for grade 1 to 3 and fair for unilateral grade 4, worse for bilateral grade 4. Sugar, frequent monitoring, target 46 to 180. Hypotension, treat aggressively. Sodium, use double walled incubators for adequate humidity. These are the few things we can do to improve our neurological outcomes so that I hope that in the 21st century, the intact survival of preterm, especially extreme preterm babies, will be a common thing. Thank you. Thanks a lot.
Thanks, Dr. Rahul. It is an excellent presentation as usual. And there's only one question in the question box you can quickly answer. Combined role of phenobarbital in reducing bilirubin as well as controlling seizures. Your comment.
Yes. This one, phenobarbital, what happens is that phenobarbital exists in acidic, phenobarb is acidic. Now what happens when we give phenobarb to any baby, how much phenobarb will go to brain, how much phenobarb will go to the body? That is described by acidosis. Second is malnutrition, presence of fat or not. Another thing is flow to brain. So this extreme preterm baby, especially IUGR baby, it is already acidotic.